And joining us now on the debate for the full hour tonight, Antonia Maione, Director of the McGill Institute for the Study of Canada. Dr. Samir Sinha, Director of Geriatrics at Mount Sinai and University Health Network Hospitals in Toronto. Dr. Nadine Caron, General and Endocrine Surgeon with University Hospital of Northern British Columbia in Prince George. Dr. Ali Okawat, Resident in Family Medicine at McGill University. And Scott Robertson, Chief Nursing Officer for the Northwest Territories Department of Health and Social Services in Yellowknife. I'm not sure we've ever done a program where more people have come a further distance to be with us around this table. But it's great, and it's nice to meet you, you Action Canada fellows, you. Okay, election campaign. We're hearing a lot about debt and deficits and spending and jobs and the economy. But what's the number one issue on Canadians' minds these days, like I have to tell any of you? Michael, let's bring this up if we can, please. Here's Nick Nanos, his research. He was just in the field a couple of weeks ago, and there it is. Number one, healthcare. Almost 30% of Canadians polled said that was their number one concern. Jobs and the economy, well behind. Education further down. The environment, debt and deficit, and not sure everybody else, but healthcare is still number one in a major way. We have seen, I guess the New Democrats have been out with some campaign ads showing how some patients are getting triaged in Tim Hortons, which actually happened one time, a Tim Hortons restaurant in a hospital lobby. StatsCan says there are more than 4 million people in this country who still don't have a family doctor. So let's start there. Antonia, to you first. If we could get more doctors and if we could get more hospital beds into the system, how far would those two things go to solving the accessibility issue in this country?
It's a very good question, and the fellows around the table who are on the ground in the healthcare system will be able to tell you exactly what they think. But I think what we should recognize is that every new bed that we put into the system, every new doctor we train into the system means more money that we'll have to spend. We'll have to spend to train that doctor and to pay the doctor, but also in terms of the beds and how expensive it is to keep beds open. So I think what we should be thinking about when we talk about access is to really ask the question, is that going to get us better access to care? Are hospitals and doctors going to get us better access to care, or other things we can think about, things that we've heard about in the campaign, like home care, things that we know are important, like payment of prescription drugs? Are those things more important than actual bricks and mortars, beds, and training in medicine?
Okay, that's it. Scott, let's go there. What would you say to the better question, actually, that Antonia just asked?
Well, I think it's a very good point that when we talk about access, healthcare isn't always about doctors and hospitals. It's about providing access to the service that people need. And nursing is certainly led the way in this. In the North for hundreds of years, a couple hundred years now, we've had advanced practice nursing delivered in our small communities across Northwest Territories and in remote areas, and that model has shown that it's a good use of our resources. So I think it's about looking at how do we better utilize the resources and the expertise that we have in the system with nurses, nurse practitioners, and other care providers, our pharmacists, our physiotherapists, our dietitians.
We tend to think, Samir, that it's about bricks and mortar and more docs in the system, but obviously, I mean, Antonia's right. It's way more than that, isn't it?
Absolutely, and I think one of the fundamental things we have to understand when we think about healthcare in today's society is that healthcare we're in a different paradigm than we were when we set up the Canada Health Act. In fact, when we founded Medicare, one thing I always try and get the message across is that when we created our healthcare system, the patients were very different. Right? We're dealing with a younger population with acute issues, and so when Medicare was set up to deal with acute issues in hospital beds, that was the issue. I don't think the answer is building hospital beds. I think it's actually understanding who the population is now. It's an older population. Chronic disease is what defines what's actually driving healthcare costs. And so what we have to do is look at how do we have to change our primary care, our acute care models to actually better meet the needs. Because I don't think if you build more hospital beds, you'll fill them, but not necessarily providing the right care that we need in our society at this time.
Nadine, would you agree with that more hospital beds does not necessarily mean more and better health care?
Nothing's for sure, and that's the unfortunate thing about healthcare. It's certainly more complicated and more complex, and so I definitely agree with what Samir says. But coming from the north, for example, up in the Northern Health Authority, the northern 2/3 of British Columbia, you're not going to run into too many people there that don't think you need more doctors. I mean, we are having difficulty finding doctors, keeping doctors, and even when we do find doctors, having them come within Canada. And so the whole concept of international medical graduates, or IMGs. They're wonderful to work with. They come well trained. They want to be there, and we love having them. But at the same time, at what cost to their home countries that I'm sure misses them, you know. And so the whole, it's more than one thing. So do we need more doctors? We certainly do. We need to build up primary care. But is that going to fix the problem? Well, no. It's going to fix one of the many problems we have. And so I think the whole issue about what happens before you need a doctor, the preventative stuff, and then what happens after your doctor's cared for you and you can go home, but you need all those extra supports like Samir is going to be able to tell us about, and Antonia alluded to, home care.
Well, here's a guy who's a doctor, and you want to have a nice long career as a doctor, right?
Absolutely.
How far into it are you right now?
So I'm in my first year of residency at McGill, and one of the things that I've noticed as I've gone through the system is, to highlight what was said, healthcare doesn't necessarily come from the healthcare system.
Explain that. What does that mean?
So just to take a step back, when you look at the OECD data for the past 30 years and you notice healthcare expenditures with healthcare outcomes, you don't actually see a clear trend. The countries that spend more money on healthcare aren't necessarily, in terms of quality and access, getting the best outcomes.
No, it's about spending smart as opposed to
spending more. It's about spending smart, absolutely. And so within the context of our healthcare system, we can think about improving efficiencies, but we also have to think about the other services that are given, not just in terms of home care, not just in terms of improving the teamwork in healthcare, but thinking more along the social determinants of health and how they contribute to the healthcare citizens.
Well, fair enough, but what kind of doctor are you trying to become?
A family physician.
You want to be a GP?
Yeah.
Okay. Are you trying to tell me that if you increase the number of GPs in the country right now, and remember, there are people who live within an hour of this studio who can't find a doctor. You know, never mind northern British Columbia. There are people within an hour of this studio, Midtown Toronto, who can't find a doctor. If you had 50% more doctors in the country tomorrow, you're saying that people's access to health care wouldn't be better?
But is it necessarily the doctors who are really providing that care?
You're the gatekeepers.
They are the gatekeepers, but when you think about, for example, the types of readmissions that you get to hospital, when somebody, I'll give you a very firm example, when somebody has a heart attack, they're at risk of developing something called congestive heart failure. 25% of those patients are readmitted to hospital. There have been pilot programs across the country whereby providing extra services at home actually prevents those readmissions, whether it's public health nurses going to the home, whether it's increased education surrounding their health. And so this just to highlight that there's a great role for those support services to play in helping patients improve their outcomes, and at the same time helping the healthcare system save money and improving overall efficiency. So it won't necessarily be the healthcare practitioners, doctors specifically, who will make the healthcare system better, but looking at the system as a whole and looking to see where the synergies are.
Let me pick up on the money angle with you, Antonia, because healthcare, as we all know, is devouring every province's budget. And I think we just had a budget out in Ontario, and I think it's 46, 47 cents of every tax dollar in Ontario we spend on programs goes to healthcare. Would spending more help?
I don't know how much more you can spend before you spend everything, you know, your whole kitty on healthcare. So that's why you mentioned spending smarter. That's certainly one way to think about it, is where are we going to spend to get the best kind of outcomes or results for the money that we spend. The problem is that we have a healthcare system that is structured along very expensive kinds of ways of dishing out healthcare, right? We have expensive hospitals with expensive technology. We have practitioners who are highly trained but also very expensive. We pay our doctors very well compared to many other countries. And so in all of that, you have to think about how much more can the system give in order to be that much better, if you will, or give that much more. So I think there are efficiencies to make within the system that can help, and there are less expensive kinds of health services that can be thought about as ways to take the burden off the cost crunch. The other part of the equation, though, is of course consumer demand and what consumers expect, what they expect from healthcare, what they expect from government as well. So that's the other thing that has to be factored into the equation.
They expect Cadillac care, and they expect it for free.
Well, they're paying taxes last time I checked. So
no, but you know what I'm saying.
That's right.
They don't want user fees, they don't want co-payments,
right.
they don't want anything.
That's right.
That's the way it is. Nadine, let me ask you again about practicing in remote areas. We talked about the fact that even within an hour of the studio, it's hard for people to find a doctor. But practicing in, now do you consider her the North? I mean, you're Yellowknife. She's only northern British Columbia. You're Yellowknife.
We're both rural, and even in Yellowknife, Yellowknife is considered to be the south part of the North.
I see. I see. Presumably you have to practice medicine in a dramatically different way than somebody on University Avenue in Toronto, don't you?
To some degree. Now, I'm in Prince George, so it's a population of 80,000, which is a metropolitan compared to the rest of the Northern Health Authority. So,
but how far north of the biggest city are you?
Well, if you sort of look at some of the more regional and tertiary care centers, for example, if you need to see, you go to the cancer center, major trauma center, like meaning the primary trauma center, which is in Vancouver, Children's Hospital, Women's Hospital, all those subspecialties.
How far away is that?
Oh, 800 kilometers.
800 kilometers. You're a long way up there.
And you're the closest, and you have to remember that the rest of we're sort of the umbilicus of the northern BC. So for all the others, when you look at a map, it's actually quite it's not as close as you think from places like Terrace, British Columbia, or Smithers, British Columbia. As the crow flies, it is. But if you're driving, which is the most economical way for one person to gain access geographically to a specialist, they have to drive all the way through Prince George and then south. So it's not unusual for a patient to travel 12 hours to see me.
For a patient to travel 12 hours to see you, if you live in Yellowknife, do you expect, as a matter of course, substandard care?
I don't think so. I think that Northerners expect to have good care, and I think that Northerners have very good access to care. But it comes at a cost. I mean, Yellowknife is on the road system, but most of our 33 communities in the Northwest Territories are not. And the only way to access more advanced care is to fly. And that's a cost that's one of the reasons why our costs in the North are very high to deliver care. Nunavut is another good example. I mean, none of their communities are connected by road. None of the territory is connected by road. So we provide access to services in your community. But if you need something beyond that, it becomes a very big expense of the system to get you to where you need to go. But the system does get you to where you need to go.
Let's talk about the ticking time bomb that everybody around this table no doubt hears on a daily basis. Michael, if you would, this from Maclean's magazine. Already, those 65 and older consume 44% of the provincial and territorial health spending. 30 years ago, health spending accounted for an average of 29% of provincial program costs. Now it tops 39% on average, and in Ontario, eats almost 46% of program spending. Today, about 14% of the population is 65 years or older. Their numbers will double in the next 2 decades, while those 85 and older will quadruple. What impact that will have on healthcare financing while the workforce shrinks proportionately is anyone's guess. Okay, Samir, you're the geriatrician. I'm coming to you first. First of all, I'm guessing we have a system right now that understands that reality, but is not yet prepared for it.
Absolutely.
How many geriatricians do we have in Canada?
Well, right now there are about 60,000 physicians in Canada. Less than 200 are actually trained to practice geriatric medicine.
So we have 200 people getting ready for this onslaught of a demographic time bomb. And is that enough?
No, and currently if we didn't advance the demographic imperative ahead of us, right now in today's the workforce projections say we need about 600 to 800 geriatricians just for the current demand for our services, and that's before we actually double this proportion of the population. So
do we have those numbers in the med schools of this country right now?
No, I think of the recent CARMS data. This is the data that comes of students actually looking to when they graduate from medical school, what specialty they're going to. Less than 3% have expressed an interest in geriatric medicine, but we definitely do need more practitioners, not just physicians, but also nurses and other healthcare and social care professionals ready to help manage the needs of this aging population.
As it happens, one of those fewer than 200 geriatricians lives across the road from me, and I've talked to her about this many occasions. And one gets the sense that all you people going to medical school, y'all want to be cardiologists, and everybody wants to be a superstar. Do you somehow need to make geriatric care cooler? You know what I'm saying?
I think it's interesting because when you actually look at lifestyle surveys or surveys of job satisfaction, when you look in the data in Canada or the US, it consistently shows that geriatricians are actually the most satisfied physicians there. Yet we remain the lowest paid specialists in the system. And why is that? It's mainly because when I actually do a comprehensive geriatric assessment, it takes me an hour and a half to do that with a patient. A lot of patients come to me 85, 86 years of age, 101, who I just saw yesterday in the home. And their first appointment's an hour and a half, and they've never spent that much time with a doctor before in any one shot. And it's the idea that it takes time to manage the issues for these patients, that we take care of the whole patient. We try and understand their issues, and many of these patients are struggling with chronic health issues. They have many different specialists helping them out, and we try and take a holistic approach, but providing that level of care that this population will require, it's time consuming, and that becomes expensive.
Do we, Antonia, have to relook at the way we pay specialists? Do we have to pay geriatricians more, for example, than we have in the past in order to make it more attractive for people to go into that line of work?
Well, this is a much bigger issue than it seems, because one of the founding blocks of our healthcare system, first in across the provinces, is the fact that physicians have been able, on the whole, to retain their fee-for-service medicine. So that is to say, they're paid by the act rather than being salaried or a capitation as we see in other countries. Now, there are certain kinds of physicians who will accept salaries, certain kinds of hospitals that make that available. But in the mean, we pay doctors on a fee-for-service basis, which is...
which means it pays them better to get people in and out faster.
Well,
so
there is this sort of idea that volume is important, right? And if you're a private, you're a private entrepreneur as a physician, you're nobody's employee. Therefore, in that sense, yes. The volume is important, and the volume drives up costs.
Can I ask you, I don't want to embarrass you. If you don't want to tell me, don't tell me. But are you fee-for-service? Are you on salary? How does it work?
Yeah, no, geriatricians in this province, across Canada, we're all on a fee-for-service basis. And that really does mean that a good day for me seeing new patients is 4 or 5 patients a day. And so because of that, we tend to earn a lot less. So geriatricians currently are looking to negotiate a salary basis. And we're not saying that we need to be paid more than anyone else. We just want to be paid the same rate that other specialists on average are getting paid. And when you actually look in Britain, for example, in Britain, all specialists are paid the same salary. Geriatrics is actually the #1 or #2 specialty in medicine, because people actually, it's a great specialty to be in, but if you're a graduate out of a medical school with a lot of debt, and you could either make 2 or 3 times as much as a cardiologist versus a geriatrician, you don't have to be a rocket scientist to figure out what choice sometimes people will make.
So have I got this right? In Britain, if you're a cardiologist or an endocrinologist or an ENT, they're all paid the same fee schedule?
Paid the same salary.
Is that right?
Salary.
Same salary?
Yes.
Okay. Do you do stuff for free as well?
I do a lot of stuff for free, because a lot of the work that I do to care for my patients, whether it's answering a telephone call, if it's doing extra work, I make little medication sheets for my patients. That takes time, but I know it delivers better care, and it's the care that they need. But a lot of that is unreimbursed work that I do.
Do you feel prepared, Ali, as a guy who's a GP, but whose patient rostrum, is that what you call it, is apparently going to be older in the future as opposed to younger? Do you feel that you have been adequately prepared for the issues that you're going to be seeing as you get out the door?
I think residency programs across the country are ramping up their training in geriatrics. But the more important question is not so much how much education we get, because again, I think that type of model focuses on the doctor as providing all the care. I think the more important question is how are we setting up the system to enable physicians as one actor within the healthcare system to manage this silver tsunami that's been said to be coming towards us. I think that's the much more important and pressing question.
I love that expression. Where'd you come up with that?
We had it in the dialogue this morning. The
silver tsunami. Boy, that's good. Yeah. That's good. All right, let's do one more here. This also from Maclean's magazine. Again, on the issue of geriatric care, and here's another one of those numbers that is a little scary. On any given day, Maclean's reports 7,550 acute care hospital beds in Canada are filled with people who should be in long-term care nursing homes or in rehabilitation. Annually, that's 2.4 million hospital days at $1,000 each, $2.4 billion a year, spent warehousing elderly people, often to their detriment, while denying space to critically ill patients. Okay, Nadine, why do we do it that way?
Well, they come in, they need acute care. And it's...
Acute care meaning?
I mean, acute care, they're coming in through the emergency room, or they presented to Ali and his family practice office, and he's decided that they needed something that required hospitalization because of whatever illness is being diagnosed. In my situation, it would be whatever surgery was suddenly required. It happens electively in surgery as well, because something's planned, but unfortunately complications happen, or they don't respond to the treatment, and so they're there for longer than you expect. They have to be ready to go home. They have to have a place to go home to. They have to have a home. they have to have someone that can look after them in the home if there's things that they need to do. Anything from mobilization, if you're talking about recovering from an orthopedic operation, to nutrition, if they're recovering from a general surgery operation, to monitoring medications, especially in the geriatric population where things like confusion and weakness and those things are just exacerbated by an acute hospital stay and the illness itself. We need a place to put them. And we need a place that's safe for them, and ideally in the home with home care provision, and if not, ideally in step-down areas where they're not in the acute setting, when they're away from sick people who could suddenly make them even more sick with the secondary infections that you get in the hospital. It's just, and then all of a sudden the hospital can be used for people who need the acute care. So that $1,000 a day is actually pretty cheap for someone who you're saving their life, or needs that surgery to improve their quality of life or add years to their life.
But everybody, of course, wants, Scott, not to be in hospital. They would rather be at home if they could be, getting good home care. Why don't we do that?
There are 2 points to that. The first point is let's do other things to keep people out of the hospital in the first place. Samir in his work you've done some very innovative things in looking at ways to keep people in the home longer. And the primary care team approach, where you have physicians, nurses, nurse practitioners, social workers working together, can actually dramatically reduce the number of admissions to hospital and keep people in their home longer. And that's the best place for them if they can be there. And then the other part is then what can we do to provide more support to get people out of hospital beds and back into their homes. And why we don't do that, I don't know, but I certainly think that it's something that we've all advocated for. I think that anyone that works in the healthcare system now sees the need for home care and the benefit for home care services, enhancing that, and but it's getting away from that acute care, that hospital-based model, and looking at how we deliver healthcare outside of those walls and see it more as a community approach than as this building with this symbol on it with these people in it.
Let's get a real life example here. You give me an example of somebody who you treated effectively and therefore didn't need to go into the hospital, didn't need to have one of those acute care beds which prevented somebody else from getting into it, which was part of this $2.4 billion a year we therefore didn't need to spend.
Absolutely. I mean, so one thing that we've done at Mount Sinai and the University Health Network hospitals here is we've developed a model of care that really starts in the community, because we understand our older patients, they don't just magically appear in the hospital. They come from the home, and our goal is to get them back to the home whenever possible. But as Scott was referring to, we've launched a partnership with the House Calls program. It's a Ministry of Health funded program. Costs only $480,000 a year, but it works with some of the most frail, vulnerable, homebound seniors. So these are elders who couldn't actually come to their family practice. In fact, they've become disenfranchised from primary care because just due to mobility or cognitive issues, they can't go to a traditional family practice office. So we have a team that will actually go into the home to provide their home-based primary care. So there have been many examples where patients will develop an acute issue, but we can wrap around with home care services, other things to meet their needs as we need them, and therefore prevent them from actually having to come to the emergency department. And on the other hand, there's a reason why there's 7,500 people a day sitting in hospital beds, because do we even fund our home care services well enough in this country to actually provide the level of care they need? I was doing a house call yesterday. I had an 86...
Sorry, say that again?
I was doing a house call.
I'm sorry, say that again?
Yes, I was doing a house call. Because this
you
is
guys still do that?
We believe very strongly. Geriatricians, and we're trying to promote this more, trying to bring back a dying art. You know, when you look back into the 1930s, the 1940s, 40% of primary care visits in this country were delivered in people's homes. Less than 1% of those sorts of visits are actually done. But I have a whole bunch of patients who I've treated at the hospital. We've gotten them out quickly, got them through into our House Calls program, and we get them home. And I can't be so arrogant to think that, well, just come back and see me in my clinic. Because you know what? They won't come, because they can't. Because the only way they can come is if they pay a $150 ambulance fee each way to bring them to my clinic, because they're that frail. So I just get in my car and I go to the home and I see them there.
Two money questions then. By going out to them instead of staying in your office and having them come to you, that's probably 2 or 3 fewer patients that you could see over that same period of time.
You're absolutely right.
So it cost you to do it.
But it's the right thing to do, and I'm hoping that by demonstrating this model, by showing that this is the right care that actually saves money for the entire system, and if we were actually just even double The minuscule amount that we actually fund in this province on home care, I can tell you that ALC crisis, this alternate level of care crisis where you have these patients bed blocking, which is a negative word to use, but these patients that we blame them, it's actually because we're grossly underfunding an essential part of our system.
Okay, second question on the money then. You said that program that you're involved with is not even $500,000 a year. Yeah. For that money, how much do you estimate that you've probably saved the healthcare system? Can you guess?
I'll tell you that for every patient in our house calls program that we're able to actually keep out of a long-term care bed for a year, sometimes we just delay that inevitable go into a long-term care bed by a few months, or even the avoidable hospitalizations. For every person that we keep out of a bed, and we have about 150 patients in that program right now, very frail patients, but everyone that we keep in home for a year saves the system about $50,000 to $60,000. So with just 10 patients alone that we keep in the home, so what we need, so what we'd love is the ministry just to even double that funding. We could actually help more of Toronto and even span this program to all of Canada.
How well are we doing at home care right now?
Not so well. For several reasons. One is that, as Samir mentioned, the Canada Health Act and the healthcare systems that we set up in the province aren't really focused on what happens outside of hospitals, what happens in the home. So home care is one of these big gaping holes in our healthcare system. And it's interesting because countries around the world, most countries that have public systems have some kind of public home care system. We have decided in Canada to fund what we fund 100%, but the things that we don't fund, we kind of leave out there. And these are really important parts of healthcare.
Home care is not publicly funded?
Well, it is, but not to the kind of point that it should be. And it goes on a province-by-province basis. It's not something that's actually mandated, right? And so some provinces have good home care programs, some provinces don't. That's why we're hearing about home care in this particular election. All of the parties seem to be floating around the home care issue because it's seen as a big gap in the healthcare system.
Ali, again, I don't want to embarrass anybody here today, but the notion of doing house calls, is that something that you guys entertain when you were educated?
Absolutely. When I was at U of T Medical School, we did house calls as part of our training. I just did another house call, I was saying this morning, about 2 days ago. And I think it's essential, not just that we do the house calls, but we identify the patients that are most at risk. So you showed a statistic earlier that was showing how the percentage of the pie, essentially, that seniors are going to be demanding of the healthcare system. I think it's more important to look at which number of seniors or which percentage require a disproportionate amount of care, and then to focus our preventative services in keeping them in the home, you know, and to target our healthcare to preventative treatments for them, and to focus it on in the home care.
You know, I don't want to assume, I never want to assume that I know what the viewers are thinking, but I'm betting that there are some at home right now saying, the guy's on TV, of course he's going to say he'll do house calls in the future. Yeah. But behind the scenes, you know, when you're on your 36-hour call some night at some hospital, you guys probably in the staff room or somewhere say, you know, I did the most ridiculous house call today, and I'll be damned if I'm going to do another one of those. I mean, isn't that...
You know, I haven't actually heard that. And here's what I'll say goes on inside those rooms. What goes on inside the traditional doctor's lounges are discussions around, I can't get access to this treatment for my patient. And I honestly believe that if you survey doctors across the country, what they'll be talking about is trying to get access to the services that their patients need and keeping them out of the hospital. It comes down to better care. And if Samir has to take time out of his schedule, and if I have to take time out of my schedule to visit a patient's house, and I can feel very confident that by doing that, I can keep them out of the hospital and I can improve their quality of life, I can't imagine any physician who will say that they won't be going to great lengths to do that.
Samir.
I'd like to think that, you know, the reality right now is less than 1% of the primary care visits that are done in this country are done for patients in their home. And we know that you know, while we talk about the aging demographic and we say the silver tsunami and all these patients are going to consume the issues, we actually know that only about 20% of older adults, a very small proportion of the older population, is really burdened with a significant amount of chronic disease. Most of the elderly out there are living longer, they're living well, and they'll age very well. But there's a small proportion that are disproportionate users of services on a daily basis. And it's targeting those services. But there are a lot of primary care physicians who tell me, you know, I'd love to be able to do house calls, but you know what? it doesn't make economic sense for me to do that. And therefore, a lot more patients are not getting access to those services. So that's why even in our program, it's not for anybody who'd like a house call, it's for these patients who would have otherwise never been able to access it.
Antonia, and then Ali again.
And let's remember that home care, while the house calls issues is interesting, kind of back to the future kind of idea, home care is also about lots of other people who are involved in patients' care. And so the things that Scott comes up against, for example, in the north, or Nadine in trying to keep patients out of the hospital before they have to see her, that's really important. I mean, it's about having a support network of health and social services, right, that can keep these elderly, or not even, you know, not only elderly patients.
And in partnership with families.
Exactly.
Who are the main
caregivers. Exactly.
Absolutely.
Yeah.
Ellie.
I just wanted to build on the previous point that I was saying. It's not so much that physicians will try to do the best for their patients, and for sure there will be some who will, because of various factors, they simply won't be able to do the house call because the system is not supportive of that right now. But I guarantee you that if you put a system behind them where either the house call or the allocation of resources to that patient within the home is made available, no physician would deny preferring that the patient gets taken care of in the home than coming to the hospital.
I know for a fact that all the doctors at this table have halos on. You guys have really impressed me. But I want to introduce another semi-controversial element into this, and that is that there is work that you do, and maybe you do too, that he could be doing. And more nurses, I'm told, feel that they can be doing work that doctors used to do, but that doctors don't need to do, but that doctors want to keep doing and not let nurses do because they don't want to give up the income. And we get that. How much of that is a feature of your regular life in Yellowknife?
It's a common discussion with nursing across the country and around the world, and the good thing is we have research to support that. You know, this is not a new concept, and the North was one of the testing grounds for that, because we had nurses are across a very large landscape with limited physician visits, so we've had to work in an advanced role for many years. So really the birth of the nurse practitioner idea really came from northern and remote and rural areas. And the research shows that nurses that work in an advanced practice, an advanced scope, provide excellent care, provide very good care. And really, nursing has the same conversations within itself as well about other providers, about different categories of regulated nurses doing a nurse's job, or what about care aides doing nursing jobs. So it's figuring out what's the best role, the best utilization of your skills and abilities. Because sure, there are a number of things that I could do that Samir can also do, but really, don't you want him using his expertise to focus on things that are really complicated, that are really beyond what I'm able to do?
Not if he has to take a 1/3 pay cut from his already too small salary because you're taking away his income. I'm just being a little provocative here, but that's what people like the Ontario Medical Association would tell you.
Yeah, I'm not going to enter into debate with the
come on, go ahead.
the Ontario Medical Association, because I don't have all those numbers. But I don't think it's necessarily an issue of taking away money. I think it's a matter of, what would you rather spend your time doing? For example, across Canada, the CNAs, the Canadian Nursing Association, did a study a couple years ago, and 40% of a nurse's time is spent doing administrative and clerical tasks. Is that really the best use of a nurse's time? No. I would much rather offload that sort of work onto somebody else that could do it, so I can spend my time doing patient care and doing the things that I'm trained to do and that I'm expert in. And I don't think that anybody around the table could argue that, anyone across the country could argue that. And where we also have to shift this conversation. It's not about what I want, it's not about what physicians want, it's not what about pharmacists want, it's about what is in the interest of the patient. And for so long, the conversation in healthcare has not been around what's the patient, where's the patient in this conversation? It's all about, doctors, nurses, this, but really when it comes down to it, if it's going to be patient-centered care, then the patient has to be at the center of the conversation.
Well, let me ask Ali, are you prepared to forego some of the income that traditionally goes to doctors and let nurses do that work so that your time could be better spent doing something else?
I think the payment mechanisms that we have so far can definitely be changed to incentivize us to provide better care and different care. So if there are boundaries of practice or boundaries that could be extended, if it's a nurse practitioner that's doing it, or a physician assistant as they're emerging in the country, I would say yes, of course I would be. There's no shortage, I believe, of treating our patients with the utmost care and providing care to them whenever we can. There's no shortage of that will, and the demand is there, and it's only going to grow. So if other health professions want to come and initiate that discussion about where is their expertise and where could they help us, as I would be helping them to serve the patient the best in the team. I think that's definitely something that I would be moving towards. One of the other things is, as we move towards different payment models, pay for performance is going to be very, very, very important, and encouraging this type of practice where you're not just paying people based on getting as many patients through, but you're paying them based on this idea of helping your patients to prevent these illnesses and helping them to meet certain targets.
Scott?
And the other idea that Ali brings up, the very important point that Ali brings up, is the concept of a team, is that we have to stop talking about what are what's in it for doctors, what's in it for nurses, what's in it for pharmacists, what's in it for physiotherapists. It's about how do we organize our team to work together to provide the best patient care that we can, because no one can argue with that.
Okay, but Scott, I'm going to argue with you a little bit here, just for the fun of it.
Sure.
You know, this guy went into med school to become a doctor and not to become a nurse, in part because, let's be honest, that's a more prestigious gig. Within the healthcare system, what you do is more highly valued than what you do. I'm sorry to say it, but that's part of the snobbishness of the healthcare profession. Am I right? Of course I'm right. I don't need you to. Yeah. That's true, though, isn't it? Come on, Scott.
Well, yeah, certainly there are prestigious ideas about the roles that we play in healthcare, but I didn't choose nursing because I wanted less prestige. I chose nursing because I saw that as a fit with what I wanted to bring to the healthcare table and what I wanted to bring to patient care. So I don't think it's necessarily an issue of money, and I think that saying that, you know, I'm going to take away money from Ali by doing some of his job, I think that's the wrong idea, because there's no shortage of work to go around. I think what it becomes is that if I do more, that allows you to focus on, you know, taking on more. There's no shortage of people waiting to be seen in the system. So if we are all doing more within our scope to look after patients, then people get better care. But it's a matter of coordinating that between us so that we're all on the same page with the plan, and also that you're doing, you know, I'm doing the most that I can, and then you're able to do the most that you can.
Let me hear
next
Samir.
specialists and.
Let me hear Samir and then Ali on this.
No, absolutely, and I think, like, when you look at the field of geriatrics, for example, we always say that geriatrics is a team sport, right? So, you know, at Mount Sinai UHN in our house calls program, we have about 20 healthcare practitioners. The majority are not physicians, right? The majority are nurses, social workers, nurse practitioners. We have, you know, therapists, etc.
But the doc still feels like the captain.
No, we all feel like we're a part of a team. See, geriatrics is a whole specialty, and there are a lot of other areas, like primary care is moving towards a team-based approach, because in my clinic, I can be a lot more efficient. You know, if you even look at it from a fee-for-service model, doctors don't mind working in teams because, frankly, when I was in clinic the other day, had a 91-year-old gentleman, gave a fresh diagnosis of dementia. You know, his daughter was asking, what kind of activities could I get involved in? How do I hook up with home care? Got on the phone, my occupational therapist came in the room. Then the social worker came in the room. Then the nurse came in the room. Then our pharmacist was there. We were able to do all of that work as a team to help that family in need, and I was able to be much more efficient than me trying to guess as a physician out of my element without that expertise.
That's because this generation of doctors has less ego than the previous generation of doctors.
And we should capitalize on that. We should capitalize on that.
Telling it like it is. Okay, Ali, then Nadine.
Just a quick point regarding why people go into medical school. There's countless surveys that are done for motivations, but I'll tell you my own, and as well as I'd argue a large percentage of the people who are going into medical school today, and that's at which issues do you want to tackle in your patients, and at what level of care do you want to provide it? I had a discussion this morning with Howard Abrams of Mount Sinai, and he was describing a system in which they take care of elderly patients, but they're within a team. A primary caregiver, such as a family physician, interviews a patient, and they all sit behind a camera, and they watch this interview as it's going by. And he told me, I was so impressed with the types of questions that the social worker was asking. And he said, I learned so much within these teams. And I can definitely say, when I've been in part of these exact same experiences in McGill, it's phenomenal how much you learn from the other allied healthcare professionals that they don't necessarily teach you in medical school, and which then you can apply to that level of care or the types of issues that you're really interested in addressing.
Nadine.
Yeah. Well, I agree completely. There is no shortage of work. And we started off by talking about this problem with access, and the problem was lack of physicians. And so I think part of it, I have to agree with you, I think ego is a big part of it. And I think what we're trying to do, and we brought up this in our discussions today, is that we have to break that down and in some way throw away the titles and use the passion and the skills of the people behind them. You know, I've met nurses that are absolutely phenomenal in what they do and in things that they could do if they were simply allowed to do it. Similarly, family physicians, you know, we're moving more and more towards other things that family physicians can do. In British Columbia, we have GP anesthetists, you know, that step in, and I'm doing a thyroidectomy, and I look over the scrub curtain, and basically there's the GP anesthetist. And
sorry, what is it?
They're a family doctor that has done an extra year of anesthetist training. You know why?
This is a new position?
Because we don't have the ability to fully staff all the time our operating rooms in Canada with fully trained anesthesiologists.
So the boundaries of what traditionally was considered your job, your job, your job, that's breaking down, you think, right now?
Well, it's not breaking down so much as I think we're starting to use more and more of the skills that people can have. Nurses can do they can be nurse practitioners, they can be physician extenders, GPs can do the GPAs or the GPER, and similarly, we have the same debate all the way through the hierarchy of medicine. In medicine, you have specialists, but then they're always put down by the subspecialists. You know, at some point, it's really got to stop and just say, and the line I always say is, I hate to break it to you, but specialists actually really aren't that special. we have a specific interest, and in that interest, I think that we do a pretty good job. But in the end, you know, for example, up in Prince George, I work in the Central Interior Native Health Center. Oh my goodness, I provide this little bit of help for these big of issues in healthcare, and a lot of times I'm just going there and saying, pulling in the nurse practitioner, the social worker, and saying, help me out. And boy, they do things that I could never do for the patient, but together as a team, we do it. And I think that's the whole thing, is the team concept.
These are two good lines I've heard today for the first time. Specialists aren't that special, and the silver tsunami. I got to remember these ones. Let me try this. Antonio, to you first. I don't want to get into too arcane a discussion of how healthcare is funded in this country, but the reality is healthcare is considered a provincial responsibility. The provinces feel they have a certain ownership of the issue. But the federal government, obviously, through its agreements with the provinces, transfers a considerable amount of money to the provinces to let them do what they do, and there are strings attached to that money, and I guess people can argue about how strong or weak those strings are. Here's the question. Do we need to rethink that whole thing? Should the federal government be like right out of healthcare altogether, or should they take over healthcare altogether? What do you think?
Wow, that is a big issue. It's a big political issue. I think that the provincial models that we have are interesting. Remember that we have healthcare in Canada because of provincial innovation, right? We have provincial innovation in Saskatchewan, we have provincial innovation in other provinces. Quebec has done its own innovative way of organizing its healthcare system. So I think we want to remember that healthcare is something that is provided to a population that has its own specific needs. And so in that sense, it's not a bad idea to have a kind of decentralized way of administering and offering those healthcare services. How the federal government is involved is in two ways. One is, as you suggested, through the funding mechanism, primarily through the Canada Health Act, in which the cash transfers are tied to accepting certain principles about the way that provinces organize their healthcare systems. And the federal government is also responsible for certain types of people. Right?
Aboriginal
this is a constitutional, exactly. Aboriginals, inmates, and the other kinds of people for whom they have constitutional responsibility. The question that we should be asking, perhaps, is to what extent should the federal government be an enabler of change, an enabler of innovation? The reason we have all of these provincial healthcare systems is that the federal government was able to offer up money that the provinces could use in order to develop their healthcare system. So what we want to think about is maybe the federal government not so much as being the watchdog or the school principal, but really as being the enabler and for innovation and change.
And just tell me a little bit more about what that means. An enabler of innovation and change means what?
So in many ways, what we've seen happening is through the Canada Health Act, the federal government saying we want there to be certain standards across Canada about how people receive care, access to care. That somehow became transformed during the 90s and the early 2000s as the federal government sort of being the arbitrator, right? Saying you can't do this, you can do this, you can do that. Now, since 2004, we have a health accord in place which has really opened the floodgates in terms of funding to the provinces, in which the federal government has said, these are the kinds of priorities that we think are important. Priorities like wait time reduction, priorities like home care, priorities like primary care. But it remains to be seen whether or not that's actually happening on the ground in the provinces. And pretty soon that health accord is going to be up in 2013, 2014. And the provinces, I think, are going to be coming back to the table asking the federal government for sustained funding. but will they be able to show that they've ever actually made advances in those particular areas?
Well, you've dovetailed us nicely to where I want to go next, which is we're in the middle of an election campaign right now. And despite the fact that the first chart we showed off this program, off the top, was that healthcare was #1, dwarfed every other issue out there, there hasn't been that much conversation about healthcare in the campaign so far. It's been a lot of other things, but not so much about healthcare. And I guess the one line that I remember Jack Layton using in the campaign was, who do you want negotiating with the provinces when that funding agreement you just talked about expires? And he obviously thinks he'd be the best guy to do it. I want to get into some conversation around the table right now about the kinds of things you think the leaders ought to be discussing in this campaign right now that maybe they aren't so far. Scott, you want to start us off? What are you not hearing that you'd like to hear?
Well, I think much of what we've talked about around the table is, let's talk about how we're actually delivering services and what does healthcare mean, and getting away from the concept of healthcare being hospitals and doctors and being about getting the services that you require access to in order to best manage your health, and how we can organize ourselves as a team to do that. And that's a conversation that certainly hasn't happened.
Samir, what do you want to hear?
Well, I think we should have more emphasis on healthcare in this federal election coming up, given the fact that the healthcare transfers are going to be renegotiated in 2014, 2 years down the road. And when you think about issues like the aging population, the demographic, and the changes that need to occur, I agree with Antonia that we can actually see what's the role of the federal government. It still provides 25% on average of healthcare spending dollars in this country, so that's a lot of influence that it can buy. So when we start saying that we have a patchwork quilt of home care services across the country, and this is one of the greatest needs that we need, to actually help manage the needs of an aging population that might actually need that increased supportive care. How about for caregivers in the home that provide $24 billion annually of unpaid caregiving support? If everyone stopped providing care for their loved ones in the home right now, that really helps fill in those gaps of home care services right now. That would be an additional $24 billion price tag, or even beyond that. So we have to start looking at how can we influence with those future healthcare transfers issues of national priority, like a national pharmacare strategy, a national home care strategy. These are the things that would be on my wish list.
Okay, Ali, what are you not hearing you want to hear?
If you do a survey of people across the world and you say, what does healthcare mean to you? #1 is hospitals, #2 is doctors, #3 is sickness and illness. We need to transform these associations from hospitals to home, from doctors to patients, and from sickness to prevention. And the way that we do that as a federal government, as an enabler, is to set up systems of efficiencies, is to have them as the main people looking at the system as a whole and looking where are the efficiencies that we can put in. One of them, or two of them rather, that Samir mentioned that I'm a huge proponent of, are of the National Pharmacare Strategy, the National Home Care Strategy, setting up a best practices institute federally that would look to see what are the best practices across the nation to implement in various situations.
But you're talking about nationalizing or federalizing what most people think of as a provincial service. So this will be controversial.
Not necessarily federalizing the service, but federalizing the way in which we think about how that service can be delivered. So not that the federal government would be in charge of delivering the actual service, but they would be able to make suggestions about how to actually bring the care together. If there is a national pharmacare strategy or a national home care strategy, it wouldn't be that the federal government would be delivering it, but the analysis would be done at the federal level. And if the provinces want to join up, then that would be excellent. If not, they could still benefit from the best practices that emerge from it.
That's what we've done in public health here in the country, right? Public health is an issue of national importance. It matters everywhere. So it's not too long ago that we established the Canada Public Health Agency, right? Because that's a group that helps set policy and set directions that all provinces participate and deliver on the ground. So I think that's exactly what you're talking about, Ali.
Nadine, what do you want to hear that you haven't heard so far?
Well, I agree with everything so far, so this is good. A couple of things that I'd like to hear. Let's see. One is, I have to put it out there, I don't expect to hear it, but the voice is always small and the votes are small and they're going to be marginalized and continue to be marginalized, are those of Aboriginal people and the healthcare that they have, the absolutely embarrassing statistics that show the disparities that put basically Canada in the top 10 in terms of a whole bunch of health parameters, everything from life expectancy to childhood and infancy death rates and everything, to way down 65, 75 80th in the world. I think we need to recognize that. I don't think they're going to do it in a federal election because there's not enough votes. You know, yeah, we have the silver tsunami. We don't have it in the Aboriginal population. We're actually reverse that. And we have the bell curve on the other end. We have a very young population, and unfortunately some of them so young they're not even going to be able to vote, let alone be able to be the target of anyone's campaign. And I suppose the other thing is, yes, everything, prevention, absolutely, but in the end, what Canadians do want to hear, and what I think we need to tackle, and it's going to be hard, is what the heck do we do with our hospital system? What do we do with the shortage of doctors? Like, I want to hear some answers in terms of what they're going to do in the short term and then in the long term to address that. And I think part of it is efficiencies in the system, which we have talked about a lot today, in terms of everything from surgical care to emergency care to inpatient beds and how to utilize those optimally. And of course, we've already talked about that. But then in the end, wait times, access, all those things that when you could prevent it, but you can't prevent everything. And when you need it, is it going to be there for you? Is it going to be there when you need it, for the people who need it, in a timely fashion and quality care? And that's what we need to address. That is a big gap right now.
Antonia, I don't mean to suggest there's been no discussion of healthcare in the campaign so far. There has been some. Jack Layton did an announcement about the number of family doctors in the country, and he'd like to increase them. The Liberals have come out with their family pack, and a component of that is home care, some of the things we've been talking about here. But you follow politics pretty carefully, and you work for a nonpartisan institute, so tell me, from where you're sitting right now, admittedly, a week into a 5-week campaign, have you heard what you want to hear on healthcare? Have you heard enough about healthcare?
It's interesting because the distance between what people think is important, healthcare is the #1 issue, and what we're hearing in this campaign couldn't be larger. And Nadine's right. People want to hear about how the healthcare system is going to improve, what political parties can do. There are 2 reasons I think that we're not getting that debate. The first is going back to the fact that healthcare is a provincial responsibility, and that's become it's always been that way, but the federal government has, and federal parties have always had a platform on healthcare. It seems now that that conversation has changed, and there's an acceptance that, well, maybe this is somewhere where the federal government shouldn't go. So something has changed in the political conversation about the importance of healthcare, or in the importance of the federal government in healthcare. The other thing is, I think that healthcare has been often referred to as the third rail of Canadian politics. Touch it and you die, right? So in a sense, I think political parties are trying to avoid that inevitable, that if they start talking about healthcare, they are going to have to get into some of these very complicated conversations, which are not just about courting votes, but about actually doing something to make the healthcare system better.
It isn't the third rail here. We love talking about it. And we love talking about it with all of you. This was really a fascinating program, and I'm grateful to all of you for coming in today from near and very far to participate in our discussion. Dr. Ali Okawat from McGill University, and Tony Maione from the, what are you calling it? The McGill Institute for the Study of Canada.
Excellent.
At McGill University. Dr. Samir Sinha, Mount Sinai Hospital and the University Health Network Hospitals here in Toronto. Scott Robertson, Chief Nursing Officer, Northwest Territories, come all the way from Yellowknife. And Dr. Nadine Caron, University Hospital of Northern British Columbia. It's great to have all of you here. Good luck, you Action Canada fellows, you.